Hello, good morning. I am Dr. K M Suresh. I have joined newly as Professor of Ophthalmology in RRMCH. Today I am supposed to teach you strabismus. As you know very well, strabismus is the technical terminology or the medical terminology that is used for squint. Before understanding various aspects of strabismus, it is our duty to understand the actions of various muscles that are there in the eye. So today I'm going to teach you something about the extrinsic muscles or the extraocular muscles of the eye. You are supposed to know the origin, insertion, action, nerve supply, blood supply, various sizes of all these extraocular muscles, and also their attachment from the limbus. These are the important things that you are supposed to know before understanding the various aspects of strabismus. Before we study about the muscles, I think you know very well that there is a bony orbit which is in the shape of a pyramid, the apex of which is anterior and the base of which is posterior. And angle of the medial and lateral, as you know very well, all these, the eyeball, the muscles and the arteries and veins are placed inside the bony orbit. Angle of the medial and lateral walls of the orbit is around 45 degrees. So the optical axis of the eye forms approximately 23 degrees with both the medial and the lateral walls of the orbit. The medial walls of both the orbits are parallel to each other, which you have to remember. And this is a diagrammatic picture of the contents of the orbit. Grossly, it will tell you how the muscles come from the posterior aspect and they get attached a few millimeters from the limbus. The attachment of every muscle is roughly between 9 millimeters to 10 millimeters on the limbus. And at what level they are attached, that you are supposed to know. And how many muscles are there? How many extraocular muscles are there? Very easy to remember. 6 muscles. 4 are recti, while 2 are obliques. Out of the 4 recti, you have, according to the placement of these particular muscles, one is superior rectus, next you have inferior rectus, medial rectus and the lateral rectus. They are self-explanatory. The action depends upon, the various actions depend upon their names only. And you have 2 obliques, superior oblique and inferior oblique. In addition to all these 6 muscles, you have levator palpebrae superioris, which is also considered as one of the extraocular muscles. It helps in widening the palpebral fissure. The origin of the 4 recti. Origin of the 4 recti are from the fibrous ring, which is known as annulus of Zinn on the optic foramen. The anatomy of the optic foramen and the superior orbital fissure is very much important. Many a times it will be either asked as a short note or in viva voce, they can ask you various contents which pass through the orbital foramen, optic foramen and the superior orbital fissure. And hence you are supposed to know fully well about all the details of the superior orbital fissure. This is the diagrammatic representation of the superior orbital fissure, and you know very well that annulus of Zinn is in the center, and all the muscles, depending upon whether superior rectus, inferior rectus, medial rectus and lateral rectus, take origin from the respective parts of this annulus of Zinn. And you must note that levator palpebrae superioris takes its origin slightly above, and the superior oblique takes that is also away from the annulus of, slightly away from the annulus of Zinn. This is the posterior aspect of the eyeball. Here, the point of importance is that you have to remember that we see vortex veins are present in the posterior aspect. There are 4 vortex veins in the posterior aspect, and a line, imaginary line joining all these vortex veins forms the equator of the retina. That is a point to be remembered in the posterior aspect of the eyeball. As far as the muscles are concerned, you must know that the superior oblique and the inferior oblique are attached on the posterior aspect of the eyeball, while the rest of the muscles are slightly anterior. Superior oblique is attached superiorly, while the inferior oblique is attached inferiorly on the posterior aspect of the eyeball. Vertical recti, which are nothing but superior rectus and inferior rectus, run in line with orbital axis and are inserted in front of the equator. You know the definition of the equator now, and they are attached in front of the equator. They form an angle of 20 degrees with the visual axis. Now coming to the superior rectus per se. So you must know the origin. As I told you earlier, it is from the annulus of Zinn. It arises from the upper part of the annulus of Zinn, below the attachment of the levator palpebrae superioris, and continues with the attachment of medial and lateral recti. It pierces the Tenon's capsule and it is inserted into sclera at a distance of 7.7 mm from the superior limbus. Length of superior rectus is 48 millimeters, while the width of attachment is around the width of the whole muscle is also 9 mm, and its attachment to the limbus stretches from 9 mm to 10 mm. The nerve supply is from the oculomotor nerve. Blood supply is from the lateral muscular branch of the ophthalmic artery. Inferior rectus is the shortest of all the recti and arises from the lower part of the optic foramen. It is attached to sclera at a distance of 6.5 millimeter from the inferior limbus. It lies between the globe and the inferior oblique. Also attached to the facial sheath of the lower lid. Length of inferior rectus, as I told you earlier, it is the shortest of all. It's only 40 millimeters in length. Width is again 9 millimeters. Nerve supply, a branch from the inferior division of the oculomotor nerve. The blood supply is from the medial muscular branch of the ophthalmic artery. Medial rectus, largest ocular muscle. Thickness wise, it is largest ocular muscle and stronger than the lateral rectus. It arises from medial and inferior sides of the optic foramen. Passing along medial wall of the orbit, it gets inserted at a distance of 5.5 millimeter from the nasal limbus. So it is the closest to the limbus when you compare all the four recti muscles. Length is around 40 mm. It is thick. It is much thicker than the other extraocular muscles. Nerve supply, inferior division of the oculomotor nerve. Blood supply is from medial muscular branch of ophthalmic artery. Lateral rectus arises from annular tendon, pierces the Tenon's capsule and inserts in sclera at a distance of 6.9 millimeters from the temporal limbus. Length is around 48 millimeters. It is 2/3 of the cross-sectional area of the medial rectus. Nerve supply is from the abducens nerve. It enters inferior rectus on its ocular aspect just posterior to its midpoint. So there is a mnemonic to remember the nerve supply of all these muscles. You can say SO4, LR6, rest by 3. It means that superior oblique is supplied by the fourth cranial nerve, trochlear nerve. The lateral rectus is supplied by the sixth cranial nerve, the abducens nerve. The rest of the muscles are supplied by the oculomotor nerve. That is the meaning of this particular mnemonic, which all of you must be already knowing. SO4, LR6, rest of the muscles by oculomotor nerve. That is the best way to remember the nerve supply, especially so it comes for your rescue when you are answering a Viva question. You know the subject very well, but you are tensed up. So this mnemonic will definitely help you to recollect the nerve supply of all the muscles. The spiral of Tillox is an imaginary line joining the insertions of the four recti and is an important anatomical landmark while performing surgery. Especially when you are removing the intraconal mass, you must know the anatomy of the spiral of Tillox. The insertions are located progressively further away from the limbus in a spiral pattern. The medial rectus insertion is the closest, superior rectus is the farthest. Again, there is one particular mnemonic to remember: the attachment from the limbus of various recti muscles, mills. Medial rectus is the closest, while superior rectus is the farthest. Medial rectus is at a distance of 5.5 mm, inferior rectus at a distance of 6.5 mm, while the lateral rectus is at a distance of 6.9 mm, and the superior rectus is the farthest of all, and it is at a distance of 7.7 mm. Obliques, as I told you earlier, when I showed you the posterior aspect of the eyeball, I told you that they are attached to the posterior aspect, on the posterior aspect of the eyeball. So obliques are inserted behind the equator and form an angle of 51 degrees with the visual axis. Coming to the superior oblique, it is the longest and thinnest extraocular muscle, arises from common origin at the apex of the orbit, superomedial to the optic foramen, runs forward to a structure called trochlea, which is nothing but a cartilaginous ring at the upper and inner angle of the orbit. After threading through this, it becomes tendinous. It changes its direction completely and runs over the globe under superior rectus to attach above and lateral to the posterior aspect of the eyeball. Anterior fibers of the superior oblique tendon cause intorsion. Intorsion is nothing but a movement wherein the 12 o'clock meridian of the cornea moves inwards. That is known as intorsion, while extorsion is the 12 o'clock meridian of the cornea moves outwards. Posterior fibers of superior oblique to some extent cause extorsion. Now, nerve supply is from the trochlear nerve. Trochlear nerve, after dividing into 2 to 3 branches, enters the muscle superiorly. Blood supply of superior oblique is from the superior muscular branch of the ophthalmic artery. Inferior oblique, it is the only extraocular muscles not arising from the apex of the orbit. It arises anteriorly from lower and inner orbital walls of the walls near lacrimal fossa. Running below inferior rectus, it attaches below and lateral to the posterior aspect of the posterior pole of the globe. Nerve supply is from the inferior division of the oculomotor nerve. Blood supply is from the infraorbital and medial muscular branches of the ophthalmic artery. Actions of the intraocular muscles is very important. There are various kinds of actions: primary, secondary, and tertiary actions, and you are supposed to remember all the actions of all these 6 extraocular muscles. Basically, you have three axes of rotation. One is an anteroposterior axis of rotation, another one is horizontal axis of rotation, and the third one is the vertical axis of rotation. The center of rotation lies around 12 to 13 millimeters behind the cornea. There are 3 types of rotations, as I told you earlier. Along the vertical axis, you have the medial rotation and lateral rotation. Along the horizontal axis, you have elevation and depression. Along the anteroposterior axis, you have torsional movements, that is intorsion and extorsion. This is the diagram to represent various axes of rotation of the eyeball, and it is referred to as the listing plane and axis of Fick to describe the various movements of the eyeball. Most of the times you will be asked in the YOOC what are the uniocular movements and the binocular movements of the eyeball, and you must be able to tell very clearly which are the uniocular movements and which are the binocular movements. As it is evident in this particular slide, the ductions, the uniocular movements are referred to as ductions, and most of the students say ductions and stop at that, but don't do that. There are 6 ductions when you come to the uniocular movements: adduction, abduction, supraduction, infraduction, encycloduction, excycloduction. or you can say simply adduction, abduction, elevation, depression, intorsion, and extorsion. These are the terminologies that you can probably use to describe the uniocular movements. When you come to the binocular movements, it's very easy to represent the binocular movements. You can write a few arrows and then describe dextroversion, levoversion, direct elevation, direct depression, dextro elevation, dextro depression, levo elevation, and levo depression. These are the movements which are present in this particular plane. The movement which is present in a plane which is exactly perpendicular to that, these movements which I described are the convergence and divergence movements which are in this anteroposterior plane. So we must be able to clearly understand the difference between the uniocular movements and binocular movements, so that when you are asked, you must very confidently tell various uniocular and binocular movements. These are the diagrammatic representations of various movements of the eyeball. Now coming to the binocular movements, there are a few terminologies that you have to remember when you come to the binocular movements, even though what I described figuratively explains all the movements. There are a few terminologies which are attached to the binocular movements which you have to remember. Coming to the versions, both eyes open, attempting to fixate an object and moving in the same direction. This is known as versions. Binocular, they are binocular simultaneous conjugate movements in the same direction. Abduction of one eye is accompanied by the adduction of the other eye. For example, is known as conjugate movement. For example, in a dextroversion, there is abduction of the right eye, adduction of the left eye. So this movement is referred to as a conjugate movement. Types of versions, you have dextroversion and levoversion, direct elevation and direct depression, dextro elevation, dextro depression, levo elevation and levo depression, which are self-explanatory. Dextroversion means both the eyeballs are moving towards the right side. Levoversion, both the eyeballs are moving towards the left side. Direct elevation, you are not turning the eyeball to the right side or the left side. Directly, you are elevating both the eyeballs. Direct depression. Dextro elevation to the right and upwards. Dextro depression to the right and downwards. Levo elevation to the left and upwards. Levo depression to the left and to the lower part. Next, you have to come to vergences. Binocular simultaneous disjugate or disjunctive movements in the opposite direction is referred to as vergences. They are nothing but convergence. Simultaneous adduction occurs. Divergence, outward movement from convergent position, is referred to as divergent. These are vergences. And you must know a few terminologies as far as the muscles are described. So you have to know which are the synergetic muscles. It refers to the muscles having the same primary action in the same eye. For example, superior rectus and the inferior oblique. Antagonists, these are the muscles having opposite actions in the same eye. For example, medial rectus and lateral rectus, and superior rectus and the inferior rectus. Yoke muscles are contralateral synergies. It refers to the pair of muscles, one from each eye, which contract simultaneously during version movements. As I told you, in dextroversion, you have lateral rectus moving, and simultaneously you have left medial rectus moving. So these are right lateral rectus and left medial rectus are referred to as yoke muscles. Contralateral antagonists, these are a pair of muscles, one from each eye, having opposite action. For example, right lateral rectus and left lateral rectus. The right lateral rectus moves the eye to a dextroversion position, while left lateral rectus moves the eye. It moves the eye to an opposite gaze altogether. That is levoversion. And another example for contralateral antagonists will be right medial rectus and left medial rectus. You have to remember this chart whether you like it or not, because these are the primary YOC questions and most of the times it can be asked as a short note. So remembering the contents of this particular chart is very, very important. You must remember that the medial rectus and the lateral rectus have got only primary action, and many a times you will be asked in the YOC what are the secondary and tertiary actions of medial rectus and lateral rectus. Just to mislead you, you must remember that they don't have any secondary or tertiary actions at all. Just to confuse you, they may ask you what are the secondary and tertiary actions of medial rectus and lateral rectus. Here I would like to emphasize the fact that medial rectus and the lateral rectus have got only primary action, never ever any secondary actions. So superior rectus, coming to the superior rectus, what is the primary action? As the name indicates, it causes elevation. What is a secondary action? Intorsion. Tertiary action is adduction. Inferior rectus, as you know, the name indicates it causes depression, but the secondary action of the inferior rectus is extorsion. Tertiary action is adduction. Superior oblique, it turns the 12 o'clock meridian of the eyeball inwards. And this movement is known as intorsion. That is the primary action of the superior oblique. Apart from that, it causes depression and it causes abduction. Inferior oblique, it causes extorsion. It helps to move the 12 o'clock meridian of the cornea outwards. And then it also causes elevation and abduction. You must remember that superior oblique causes depression, while the inferior oblique causes elevation when it comes to the secondary action. So many a times students make a mistake of saying that superior oblique causes elevation. You should never ever do that mistake. You remember this way, while the superior recti cause movements in relation to their names. For example, superior rectus causes supraduction, inferior rectus causes infraduction according to their names. But it is the opposite in case of obliques. Superior oblique causes depression, while the inferior oblique causes elevation. You please remember that way. I would also help you by giving you one particular mnemonic so as to remember the various movements of the eyeball by various muscles. Sin rad ABO. When you expand it, it says superiors are intorters, recti are adductors, and abduction is by obliques. Superiors are intorters, recti are adductors, and ABO means abduction is by obliques. You apply the same rule to the table which I have given. I'll go back to the table. See here, superior rectus, sin means superior rectus causes intorsion. Superior rectus causes intorsion, and the superior oblique causes intorsion. The sin is completed here. Superiors cause intorsion. So you know that superiors are causing intorsion. Superior rectus is causing intorsion. Superior oblique is also causing intorsion. Sin rad, recti are adductors. See, the main adducting motion, you know very well, there is no doubt about medial rectus. When you come to the other recti, then you will have a doubt whether it causes adduction or abduction. So you have a mnemonic to remember rad. Recti are adductors. For example, inferior rectus is an adductor and a superior rectus is an adductor. Okay. So abduction is by oblique. The primary action of superior oblique and inferior oblique, you will remember very well, that is intorsion and extorsion. And I also told you that opposite action by the superior oblique as far as elevation and depression is concerned, that also you'll remember. Now, by remembering the last mnemonic, that is ABO. ABO means abduction is by obliques. So superior oblique also causes abduction, while the inferior oblique also causes abduction. Hope you understood very well the meaning of this particular mnemonic. So both the obliques have same tertiary action because they are inserted behind the center of rotation. They pull posterior pole of the globe medially. When they contract anterior portion of the eye, anterior portion of the eye is affected, so it causes abduction. Both recti have same tertiary action because they are inserted anterior to the center of rotation. And this, I've already told you, synergistics and antagonists, all these muscles. Yoke muscles and contralateral antagonists also I've described earlier. And you have to remember a few terminologies, diagnostic positions of gaze. Now you have a primary position of gaze. Primary position is the position of fixing the ocular posture. For example, when you are looking straight ahead, that is referred to as primary position. There are 6 cardinal positions, and these 6 cardinal positions, I'll tell you, they are nothing but dextroversion, levoversion, dextro elevation, levo elevation, dextro depression, and levo depression. Plus, you have 2 elevation, that is direct elevation and direct depression. Direct elevation and direct depression. These also come under cardinal movements. Primary position of the gaze, as I told you, when you are looking straight ahead, it is known as primary position of gaze. Secondary position of gaze. These are only 4 movements. Secondary position of gaze are 4 movements: direct elevation, direct depression, dextroversion, and levoversion. Tertiary positions of gaze. These describe the positions assumed by the eyes when combination of vertical and horizontal movements occur. As you know very well, when you do dextro elevation, not only it is moving along the horizontal and vertical axis, it is also moving along the vertical axis. That is dextro elevation, dextro depression, levo elevation, levo depression. These are the tertiary positions of gaze. So primary position is looking straight ahead. Secondary position are the direct movements. So elevation and depression, wherein only along horizontal axis the movements are occurring. Right movement and the left movement, dextroversion and levoversion, wherein the movements are occurring only along vertical axis. Tertiary positions of gaze are the positions wherein the movements are not only occurring along one axis, but it's also occurring at another axis. For example, dextro elevation is occurring both along the vertical meridian and the horizontal meridian, horizontal axis and the vertical axis. Cardinal positions of gaze. These are the positions which allow examination of each of the 12 extraocular muscles in their main field of action. There are 6 cardinal positions of gaze: dextroversion, levoversion, dextro elevation, levo elevation, dextro depression, and levo depression. I'll repeat: dextroversion, levoversion, dextro elevation, levo elevation, dextro depression, and levo depression. These are referred to as the cardinal positions of gaze. This is a diagrammatic representation which I have created so as for you to understand the primary, secondary, and the tertiary positions of gaze. If you write down this diagram, probably you'll be able to understand various positions of gaze. There are 2 laws that are associated with the actions of extraocular muscles. Herring's, there are 2 laws. Herring's law of equal innervation, so as to explain how the muscles move. During any conjugate movement, equal and simultaneous innervation flows to yoke muscles. That is what the Herring's law is trying to say. During any conjugate movement, for example in dextroversion, there is equal and simultaneous innervation that is flowing to the right lateral rectus and the left medial rectus, and hence the yoke muscles act simultaneously and symmetrically. Then we will come to Sherrington's law of reciprocal innervation. Innervation to extraocular muscle is accompanied by a reciprocal increased innervation of extraocular muscle is accompanied by reciprocal decrease in innervation of its antagonist. For example, in dextroversion, this law tries to say there is an increased innervation to the right lateral rectus, while there is decreased innervation to the medial rectus, same medial rectus. These are the supranuclear control of movements. Sometimes it may come as a short note, not very often, very rarely when it comes to the when you have to write down something about the supranuclear control of ocular movements. I feel that it is enough if you just remember the names of these movements: saccadic system, smooth pursuit system, and the Virgin system, vestibular system, optokinetic system, position maintenance system. These are the supranuclear control of ocular movements, which you have to remember. And I don't think it is necessary at this stage for you to remember as an undergraduate to I mean, there is no need to write an essay on these particular movements. I think if you are asked what are the various supranuclear control of ocular movements, maybe you have to mention all these 6 types and nothing more than that. I think that's enough for this class. I'll conclude it by emphasizing the fact that understanding the origin, insertion, nerve supply, and remembering various primary, secondary, and tertiary actions of all the muscles by remembering the mnemonics which I have given and remembering their attachment from the limbus, again by one more mnemonic by name Mills, wherein medial rectus is the closest and superior rectus is the farthest from the limbus, and remembering the size of the muscle and its extent of attachment to the superior to the limbus are the important points that you have to remember and reproduce whenever you are asked either in theory or in viva voce. And you have to clearly remember that the recti cause movements with respect to their names, while obliques cause opposite movements. For example, superior oblique causes, apart from its primary action of intorsion, it causes depression, and don't you ever say elevation for superior oblique. And inferior oblique, as you know, the name is inferior, but it causes elevation apart from its primary action of extorsion. Okay, so one more mnemonic which I told you, sin, rad, abo will definitely come to your rescue. Superiors are intortus. When you have to explain the secondary and tertiary actions, primary actions definitely you will be able to remember very well. When you are asked about the secondary and the tertiary actions, this particular mnemonic, sin, rad, abo will come to your rescue. Superiors are intortus, recti are adductus, abo means abduction is by obliques. With that, I would probably conclude this particular class. I think you have understood the whole anatomy and their actions. And of course, the nerve supply, again, you have a mnemonic there, SO4, LR6, and rest of the muscles by third cranial nerve. With that, I would like to conclude this class. Next, I will teach you strabismus proper.